So I'll make a presentation about the CTO intervention for the SIP patient. So the CTO PCI to the tip, the selection of the procedure with a low risk and high success rate is very important. So how to reduce the risk? The one point is prevention of the reduction of the cardiac function. So prevent the myocardial damage on the CTO vessel. So you have to avoid branch occlusion during the CTO intervention, and also you have to avoid hematoma due to the false lumen enlargement. And during the balloon dilatation or stenting, you have to avoid the distal embolization if needed. And also, you have to prevent myocardial damage around the donor artery during the retrograde approach. So you have to avoid the injury of the donor artery. This is a very crucial point. You have to avoid it. And also the major perforation of the collateral vessels. And you have to also avoid the cardiac tamponade due to the coronary perforation related with the collateral channel perforation and the CTO vessel perforation. And also you have to prevent the renal dysfunction. You have to prevent the renal dysfunction. So you have to use minimum volume of the constant media. That is very important. And also, if needed, you have to prepare support devices such as the IABP, Impera, or ECMO. And you have to avoid the continuous usage of the bifemoral approach. So if we wanted to insert the IABP or the another support devices, maybe the one femoral site should be opened. So that is also the important point. So one radial, one femoral is a good option for the CTO intervention. So, and also you have to use the appropriate selection of the antegrade, retrograde, ADER, or IVAS guide wiring. So for the success AWE antegrade approach, the guide wire should pass through into the plaque root. But if there is a calcification, the guide wire cannot be passed through this region. Or if the guide wire is get into the subintimal space, this is also the failure reason like that. So you have to move on to the retrograde approach or stingray ADR or IVAS guided wiring to solve adequately these problems. So you have to go to the retrograde approach, and you have to go to the stingray ADR, and also you have to go to the IVAS guided wiring. So just now, today I show you the recent changes of the selection of the CTO strategies, retrograde, stingray ADR, and also the IVAS guided wiring for TIPS patients in Japan. So yeah, I'm just focusing on the 3D wiring. So that's why in my hospital or around us, the Japanese doctors increase the accuracy of the antegrade guide wiring technique using the 3D wiring. And also, the Japanese doctors try to perform the IVAS guided wiring, not only for the intraplaque tracking, and also the re-entry using the tip detection method. And also, the Japanese doctors tend to avoid the risky retrograde approach, especially for the chip patient. So this is the 3D wiring. This is the angiographic 3D wiring. So if you see the, this is the target. This is the aerial view target. This is a target, and this is the aerial target. So if you see the two images, you have to understand which direction you should rotate the guide wire. In this situation, this is clockwise. So if we understand this 3D imaging rule and also 3D angiographic wiring control, you can advance the guide wire precisely get to the target like this, from around the 1 centimeter from target like this. So if you don't understand the angiographic 3D wiring, it is better to see this journal. This is open access. This is also has a video presentation of the angiographic 3D wiring. So this is the targeted here. This is a target. This is a CTO region. The target is a 0.4 millimeter small target, and the CTO length is a 4 centimeter. So you have to control the guide wire from 140 centimeter away from the target using the guide catheter, and you have to control the guide wire precisely to the target. So this is a video. So this is a 3D wiring. So if you see the guide wire tip from the two directions, you can understand which direction you should load the guide wire. So in this situation, this is counterclockwise. If you load the counterclockwise, the guide wire tip direction will scale. So this is a counterclockwise. And also this is a clockwise. These are the rules, simple rules. This is a clockwise. This is a clockwise. Next is a counterclockwise. So if you understand the 3D wiring, this is just a 3D image, simple. You can control the guide wire from 4 centimeters like this. So if you use this technique, you can advance the guide wire tip to the target. Not easily, but relatively easily to get the target. So especially for the tip patient, this technique is very important. Simple intervention, high success rate is very important for the tip patient. And also, regarding the, I'm talking about the next step. So regarding the next step of the integrated approach in the tip patient, outside of Japan, maybe it is better to move on to a low risk retrograde approach or stingray ADR. And IBUS guided wiring using the conventional IBUS is the last result. In retrograde approach, damage the donor vessels and the channels will lead to fatal complications due to the poor cardiac function. So you have to be careful about these complications. And also in stingray ADR, there is a risk of the myocardial damage due to the side branch occlusion and the false lumen dilatation. But I think that the risk is relatively low because the procedure performed only as a CTO vessel. So I recommend I recommend to perform the low risk retrograde approach or stingray ADR and you should avoid the high risk retrograde approach, especially in the CTO PCI to the chip. But in Japan, just now, we are directly moving on to the IBUS guided wiring, not only for the intraplug tracking, but also the ADR, and avoid also the risky AWE. In Japan, there is an anterior IBUS. This is a short tip pullback IBUS. So therefore, the IBUS guided intraplug tracking or the tip detection ADR can be achieved very easily. So this is a tip detection method using the CTO specific IBUS. So CTO specific IBUS is a short tip and also the pullback transducer system. It's a good IBUS for the tip detection method. So the tip detection method means that if we use the pullback system, you can see the second guide wire shaft, and also you can see second guide wire tip. If you see a second guide wire tip like this, you can easily understand which direction you should rotate the guide wire. So in this situation, this is counterclockwise to get a target. So this is a guide wire shaft, and this is a guide wire tip. If the target is located here, you should rotate the guide wire counterclockwise to get the target. But if the target is located here, you should rotate the guide wire clockwise to get the target. So this is a very simple guide wire manipulation using the IBUS guidance. So just now in Japan, we try to advance the guide wire from the anti-gravity, from the intraplug tracking like this. But if fails, we have to advance the anterior IBUS through the first guide wire. Then we navigate the second guide wire using the IBUS guided tip detection method like this. But if it fails, sometimes the calcification is very big, and it is difficult to advance the guide wire through the intraplug tracking. So you have to advance the guide wire through the re-entry route, also using the tip detection method. So this is a subintimal space, and this is a two lumen. So using the tip detection method, if it's a guide wire tip, you can directly penetrate the barrier of the subluminal space to the two lumen like this. So this is a very simple way, and also that this is a very reliable way. This is like an echo-guided venipuncture like this. So this is a tip detection ADR. So compared to the stingray ADR, this is reliable because you can penetrate anywhere you can penetrate. You can make the re-entry route anywhere except for the calcification calcifier region. So I will introduce my TIPS patient recent intervention for the TIPS patient. So the patient has three CTOs, RCA CTO, LAD CTO, LCX CTO, and the LV function is 22%. So very high complex CTO intervention and also the high risk, poor LV function like this. So the PCI was performed in the another hospital, the first PCI, but the guide wire could not be entered into the two lumen like this. Maybe the guide wire was subintimal space like this. So they stopped the procedure because there were three CTOs. So it was impossible to perform the retrograde approach. So the patient was transferred to a hospital and I performed the PCI using the IBUS guided wiring. So firstly, I tried to recognize the RCS CTO. Maybe there might be some channel might be there, but the guide wire was entered into a subintimal space. The first guide wire was the subintimal space at the PL side. So I advanced the anti-or IBUS and I controlled the second guide wire into the PDA branch through the interplug tracking. So this is the second guide wire. The second guide wire was got into the PDA lumen like this. This is the interplug tracking using the IBUS guided wiring. After that, I advanced the IBUS into the PDA branch. I advanced the second guide wire, another second guide wire to the PL branch using also the interplug tracking tip detection method. So this is the second guide wire to the PL branch. So the guide wire was entered into the PL branch route like this using the interplug tracking. So I fixed the RCA like this. Then in 2 weeks, I performed the next intervention for LAD. So the LAD, the first intervention, the guide wire got into the subintimal space in the other hospital. So I advanced the guide wire, but the guide wire might be entered into subintimal space in the same route. Then I advanced the second guide wire into the diagonal branch using the IBUS guided wiring. So the guide wire was entered into the diagonal through the interplug route. Then I advanced the second, another second guide wire to the LAD route. So this is the IBUS. So this is a diagonal branch, and this is the LAD, the guide wire. The IBUS was entered in the subintimal space, and the true lumen is located here. So it is very simple to get the re-entry route from here to here using a tip detection method. So I did it. So this is the second guide wire. This is the second guide wire shaft and tip. This is the second guide wire shaft, and this is the second guide wire tip. So the guide wire should be rotated counterclockwise because the target was located here. So this is the counterclockwise rotation. So the guide wire tip was got into the two lumen like this. So this is a very simple way to get the re-entry like this. This is just a venous vein puncture using the echo guidance. So like that. So the guide wire got into two lumen. Then after that, I advanced the microcatheter like this, and I advanced the soft wire into the LAD distal part like this. Then I put the stent, and I got the TIMIS referral like this. This is a spasm, so this is a good referral. I use only the 30cc contrast media because this is IBUS guided wiring. Then in 2 weeks, I performed the final intervention for LCX. So LCX, there might be some route. So XTR wire could be advanced into the OM branch route like this. But it was a very cultural region, so I did a rotor. But there was another main branch located here. So this is another CTO route in the LCX, but it was very difficult to advance it because of the angulation. So LCX to the OM branch, it was opened. But the LCX to the distal LCX, it was impossible. So that's why I did a screen technique. I advanced the guide wire into the this route, the LCX distal part. But the guide wire was entered into subintimal space because this was a very angulated and it was very difficult to control the guide wire. So I opened a small balloon and I checked the IBUS and I did a tip detection ADR like this. So this is a true lumen. True lumen was corrupt, but there was a target. This is a subintimal space. So this is a puncture wire. So the puncture wire was directed to the target like this. This is just a direct visualization. So the guide wire was penetrated into the true lumen like this. Then I advanced the microcatheter here. Then I advanced the soft wire here. So I got a good reflow like this. So I also used the contrast media around the 30 cc at that time. So this is IBUS guided wiring. So if we use this kind of the technique, you can treat these complex CTO interventions with a minimal contrast media and also the minimum complication like this. So in conclusion, for CTO PCI2 tip, it is very important to select the procedures with low risk and high success rate according to the country situations. I think that in India, maybe the low risk retro approach and also the ADR, single ADR should be selected after the failure of the AWA. But in Japan, we try to do the IBUS guided wiring after the failure of the AWA integrated approach. So thank you for your attention.
Thank you, Okamura, for a wonderful talk. In India also, we don't consider actually the area as Stingray crossbars is actually the second choice. Rather, we go with integrated CTO, then go to the retrograde. I just wanted to ask you 2-3 questions. Number one is actually, you told that which CTO is not a chip CTO. Can you just define that? What are the chip CTOs? Some of the CTOs are then not chip CTOs?
So I think that usually the chip CTO is also the poor LV function and also the complex CTO regions, like that long CTO region and also the cultural regions. So my thinking is like that.
No. My question is, for you, every CTO is simple. So for you, there is no CTO is chip CTO, or all the CTOs are simple CTOs, or patient should have more than 2 CTOs to call it as a chip CTO.
I think that the chip CTO is two CTOs. Yes.
More than 2 CTOs. But
yes.
You used actually 3 wires and an IVUS catheter in patient. One case, that is actually the second case. The case which you showed in LAD, in septal artery there is a wire. The wire is into the diagonal, one wire with the IVUS catheter. Can we take 3 wires and IVUS catheter in a 7 French catheter?
7 French catheter, it's okay. It's okay because I use the thermo-IVUS.
Thermo-IVUS is not available.
Available. 3 wires.
Thermo-IVUS will not give an IVUS catheter in India, you know.
Just now they are trying to export. They are trying to export. Maybe in 5 years. 3 years, 5 years. I hope.
We will get it after 5 years, huh?
Maybe I hope 3 years, 5 years. I'm talking about with thermo company to export for the foreign countries.
Because most of the things you are seeing today, we will see after 5 years. So, number one, actually, that is why our skills are not developing like you.
My question, what is the advantage of a sequence wire?
Because you tell that actually just shifting the wire to that side, this side, it will go to the plaque, intra-plaque correctly, number one. And you are always using an parallel IVUS catheter along with the wire. That technology, we always use an IVUS only to the branch and enter the proximal cap. We don't take the IVUS catheter in parallel with the wire, and intra-plaque movement is not possible because we don't have a forward-looking IVUS in this country. Okay.
So just now, I'm tracking. I'm trying to export this IBUS
I
to the
understand,
foreign country.
I understand.
Yeah.
Can
You have
just-
used the chicken wire. What the advantage of chicken wire? You have used the wire, the chicken's wire. What is the advantage of that wire?
Advantage of the IBUS?
No, chicken's wire. Your wire, you have used the chicken's wire to cross the lesion and to prevent the some intimal dissection. What is the advantage of really that wire?
So maybe I don't clearly understand, but maybe, so advance the fast guide wire into subintimal space. Maybe I advance the Corsair, not the barrel dilatation.
Okay.
Then I advance the IBUS. So because without the barrel dilatation, this IBUS can be inserted into subintimal space. So that's why maybe the subintimal space might be there, but it's not enlarging. It's not large.
Okay.
Any more questions from the?
Dr. Okamura, hello and wonderful talk. Is there any specific precaution to take to avoid subintimal hematoma when you keep the IVUS there for so long? Because we are not used to keeping it intraplaque, as
Okay.
Dr. Pratap said.
Yeah.
Yeah, subintimal.
Okay.
You did a rotablation in the subintimal space.
Yeah.
No. Yeah, I did a rotablation for the intraplaque. Then after that, I advanced the guide wire into subintimal space. But anyway, if you advance the guide wire into subintimal space, then you get the two lumen using the IVUS guided wiring. So you don't. You have to keep the first guide wire in the subintimal space. Then you put the stent. And also you advance the microcatheter through the first guide wire in the subintimal space. After that, you put the stent. Then you have to suction the subintimal space to collect the blood. So this is a good way to reduce the subintimal space. Maybe I already wrote the paper, Jack case, how to reduce the subintimal space during the CTO intervention. So please check my name and also the Jack case to reduce the subintimal space using the microcatheter.
We know Okamura. Actually, Okamura's name is synonymous with the 3D wiring in CTO in the all over the world. So we know that this is the paper. All the papers of 3D wiring cannot happen without Okamura's name. Thank you, Okamura, for the wonderful talk, and we enjoyed it. Please, thank you very much.